Mentoring with Geraldine is a bite-sized practitioner podcast for naturopaths, nutritionists, herbalists, coaches, and practitioners. This podcast responds directly to the needs of you, the practicing natural therapist. Okay, now the question is, are we on? You're now live. Yay! Oh, I'm sorry we're a little bit late, everyone. Yet again, Facebook to Zoom just isn't happening for me. So here we are. Thank you so much for hanging around and waiting. You know the deal. Do say hello and hi in the chat. And at the very end, there is a code word for you to get your certificate of attendance. So thank you, Moira. Dr. Moira Bradfield-Strydom. Thank you so much for coming in and talking to us this morning. You recently completed your PhD, which is beyond amazing. The amount of work. My sister has a PhD and my husband has multiple masters, and I did a master's that wasn't a master's because ultimately I never handed it in. And it's a lot of work. It's a lot of work. And you run a business and you've created products as well. So you are my hero. And thank you so much for coming on and talking to us today. So tell us a bit about the whole process and how you kept your business going while you're doing all this study and all this research and everything. And a family. Let's just add that in there. And dogs. And you're crafty. And you can knit. Okay. Not that I'm jealous or anything. But you can cook as well, right?
Yeah. That's not something that I can cook.
Yeah, I've got a friend who is an amazing cook. She knits, she sews, she's done all this. It's just beyond the pale. So do tell us a bit about yourself so that the audience who will turn up in a minute, who I know are late, sorry guys, can learn more about you.
Yeah. So as Geraldine says, I have recently got a PhD, but at the core, I'm a naturopath and have been for many years. I graduated in 2001. And along the way, have dabbled in different things, picked up a master's in acupuncture. Midway, I have a habit where after 10 years, I forget how traumatic study is and I go back and try it again. And then vow I'm never going to do it again, and then for another 10 years off and then do it again. And so the recent experience of that was going back to a PhD in a passion area, which I think is very important if you're going to do further study and want to maintain a business, because the two things have to align with each other and complement each other. And so I worked with looking at recurrent thrush and have a practice where we focus primarily on genitourinary conditions, and recurrent thrush sits in that and amongst the vaginal microbiome. So worked in that and maintained a business in there, which is obviously a tricky thing to do. I'm very stubborn and very good at I'm putting time to this, but then I'm also going to go and binge watch some Netflix at the same time. And so created those parameters. But at the end of the day, a PhD is an amazing process and you do learn a lot, and to do one through a pandemic is a very interesting experience also. But in some ways it's less stressful than some of those other ways that you can study, because there isn't specific terms and trimesters and due dates. Everything is flexible as an adult learner. I mean, there are things that have to be done on time, but for a large degree you're working independently and on your own terms essentially, and so things fit. And with the way that I studied, which was through utilizing the government's stipend, so the research framework scholarship, which pays you a somewhat, not really, living wage on a weekly basis. So it wasn't amazing. It was $500 a week, I think, which is meant to take care of your food and living expenses. Within that framework, you're allowed to do 10 hours of work a week, essentially. And so that became what I allocated to clinical practice. You have to negotiate that with supervisors. I allocated that to clinical practice and built a business I mean, I'd always had a business, but I think in those last few years it's grown because of the fact that I really niched down in this area and obviously was very passionate and was reading consistently and gained exponential knowledge whilst doing
Yeah.
that process as well.
Yeah. I mean, that I can't, the only way to do something like this, I think probably with the family and the business and everything else, is to get that scholarship and is to make sure that you don't have due dates. Imagine, because your child is still trying to do their end of year exam. Well, your child is younger, but still they're trying to do their end of year things, and then you're trying to do your end of year things if you were doing a degree. So all of us generally are late to the game. It's not, there are more adult learners within natural therapies than I think there are within most industries. So it's really cool that, you've kept it going, and we've got this, we now have Dr. Moira Bradfield, who's got, and it's in a science that's really supportive of us. It's not, I don't know, a social sciences doctorate. So we excuse me. So we've actually got a huge amount of learning from you. And one of the things I wanted to ask you about is the testing that you use, because I know that you send those vaginal swabs overseas. So, why have you chosen the company you've chosen? What's different about their panel than somebody else's in the States, or in the UK or in Europe or Australia or whatever? Why have you chosen the one you've chosen?
Yeah, so I mean, there's various technologies available when we look at any microbiome testing. And however, when we look at the research and the setting that predominantly that knowledge base is coming from, they're using next generation sequencing. So this is more expanded identification of an infinite number of bacterial or fungal species, and so being able to align what I'm seeing clinically with research papers means that I need that level of detail, and so within the world of the vaginal microbiome, you've got a few different forms of next generation sequencing available. 16SS RNA, which is the bacterial, or ITS1 for fungal species, or you can, for some companies overseas, there is shotgun metagenomic as well available. However, most of the research within the vaginal space is using 16S technology. And so, to utilize that research and to have that level of understanding and to inform, I'm very much into pattern recognition. And so the more detail I see, the more my brain goes, oh, I've seen that before when that person had that symptom. And so it informs my practice when I see those things. So I'm utilizing that type of testing, and depending upon where I have a global practice, so depending upon where my client sits in the world, I would choose different companies that use next generation sequencing over the others. But I prefer that over things like PCR or straight PCR panels, because of the fact that I want all the detail. I think it's important to know what specifically is there, not just what a panel tells us might be important for diagnostics, because that becomes a limitation in my practice as well. And looking at complex presentations, which is primarily people that find me have been down a lot of different pathways of trying to find help. Generally, that level of detail is required because we're trying to find answers where nobody else has found answers, or trying to find a detail that determines why they're experiencing something in a specific way, and so that testing is my favorite way to go. And so I mentioned, different parts of the world have different next generation sequencing. Unfortunately, Australia at this point doesn't have one, although I believe that in the future we will. And so it means shipping, to Australia, testing, shipping back, which creates timeline delays. But it's something that now I'm very familiar with, and I teach that level of interpretation because in my PhD we ran a trial where we looked at the microbiomes, the gut and the vaginal microbiomes, using this technology to see what the impacts of fluconazole as a medication were on people who used it long term.
Yeah. That's really, it's really interesting that the testing that we do can be international at that level. And we've got timelines. I do find them a bit of a pain, but is it going to be like a month or 3 weeks? What's your turnaround, do you find?
Yeah, ideally from getting it shipped to that person, swabbing and sending it back a minimum of about a month turnaround. The delay comes in that my preference is that people test when they have symptoms.
Right.
And so often with vaginal symptoms, you're on a cyclic circle. So you need to wait for somebody's point of the month where they have the worst symptoms. Then you need to swab that, and then they need to send that back. And ideally as well, they're not taking a probiotic or inserting a probiotic at that time, or using anything that's determined to be quite strong antimicrobials that could change that result at that point in time as well. So there needs to be a pause, usually of 1 to 2 weeks of those things, swabbing. And there are always exceptions to that. I don't want people to go backwards in terms of their health. Lots of people are utilizing antibiotics or utilizing things to hold them in a place that's not necessarily, purely cure, but it is comfort. And so for those people, then you make decisions around what you can pause, how you then interpret that data in relation to what they're using and what they have used as well.
So when we think about the things that they're on, what have you noticed with practitioners, or not necessarily practitioners, but the people that come to see you? What are they sort of overdoing? What are they doing more than they should be to try and maintain a symptom-free behaviour? There's some sort of top tips here for, we've got a few people listening in. So we've got some eyes on the prize at the moment. So what do you find as sort of the top tips? People come to you and they're doing something that you're like, please stop doing that. Or you've been doing it for too long.
I mean, there's not a huge amount of them, surprisingly, apart from the fact that you can often see the people in desperation, which is what this space sees a lot of. There's a whole part of genitourinary health that is hidden in shame and not discussed or gaslit. And so people don't have access to medications when they need it, or, are not getting support in other places. And so they turn to Reddit forums and things like that, where we see lots of recommendations of either quite strong antimicrobials like oregano oil, which we see with the gut, or people using probiotics, which is fine. They are a great tool, but perhaps using strains that are not appropriate for what they need, or over inserting them, so inserting them vaginally too frequently, or again not matched enough to the presentation. And vaginal health is, I see a bit of that, but it sort of escalates to the next level when we deal with people who have recurrent UTIs or conditions of urinary. There's a whole lot of, and understandably also quite desperate self-prescription that comes into that, where people are trying all the things and, often having to de-prescribe initially to reduce the irritation to the bladder, because everything that they're consuming ultimately ends up to some degree within the urine as well. And so, which is great for therapeutic action, but bad if there's an inflammatory component from a metabolite of a particular compound, or, it's just too reactive for them as well. So those sorts of things. And then traditionally in vaginal health, there is some, over douching, I guess, but that is something I see less and less of. I probably in the last 12 months, I've only really had 1 or 2 clients that are douching to get rid of odor, like using a water douche. And obviously that's a big habit that we need to break as well. But it's less, because when you do go on the internet, the first things you come across are, cotton underwear, less sugar, don't douche, or don't use, don't use soaps in those areas. So the people are pretty onto that, but then they find obviously that that's not enough to get relief from symptoms, because these things are so much more complex than just a lifestyle factor. And lifestyle factors need to be taken into consideration with how the body is working, what the hormonal cycle is doing, where the stress cycle is at, and what is the microbiome doing as well, in terms of specific microbes overgrowth or loss of different microbes as well.
One of the things that I notice is when I get clients' results back is the dates that they're taken. So earlier you said about, taking the swab when the symptoms are at their worst. So what dates generally within a cycle are people noticing these symptoms for candidiasis and these other problems are the worst? Is it, that 21 days? Is it the 7 days? Like, things come back at all different dates. So what are we recommending for swab date?
It depends on what the presentation is, because there's actually quite big differences between hormonal stimulus of fungal species versus bacterial species. And so when we think about estrogen, which is a very important hormone for vaginal microbiome balance, estrogen is known to stimulate a fuel source via the cells and their expression of glycogen that feeds beneficial bacteria like lactobacillus within the vaginal space. And so when we track through a cycle at points where there is low estrogen, so perhaps just before menstruation or just after menstruation, we might see more symptoms presenting that are representative of challenged bacterial spaces, less estrogen, less abundance of lactobacillus perhaps at that time. And so things like bacterial vaginosis, aerobic vaginitis are typically more likely to appear there. Whereas with candida or recurrent thrush presentations, the very same thing that fuels bacterial species can also create an overabundance of fuels for fungal species. And so in terms of recurrent thrush, peak risk times are ovulation and mid-luteal. And so there's an estrogen situation there, but there's also a relationship between estrogen to progesterone that needs to be examined, because there's a whole lot of immune dysfunction that can occur because of where those hormones sit as well. And so if we track across a cycle, understanding when somebody experiences symptoms can help to understand what a potential shift may be, whether it's a bacterial one or a fungal one. And we do have unique situations where both of those things can go on at once, and fungal presentations are frustrating. And the reason why I dug into them was because clinically I wasn't getting traction on them. And so let's go look at a PhD to solve that problem. But I was finding that, the literature tells us the bacterial environment is fine with recurrent thrush, when that isn't necessarily what's going on. We've had some recent literature that shows us that's not true. But the why of it is that, looking at what's going on in the microbiome, looking at behaviors associated with it, looking at hormonal patterns. And so understanding where in a cycle someone is getting symptoms can inform some basic differentials, and then you dig further into the details of the symptoms to understand as well, because there are differences between discharges, there's differences between odors, there's differences between symptoms in terms of inflammatory symptoms and not, between those types of presentations. And a lot of people in the public will go, oh, it's thrush, whereas that's not the most common presentation. Bacterial vaginosis is the most common presentation to see clinically, but because of the way society's being educated, essentially, if there's a discharge, there's a very common leap to go, I've got a thrush presentation. And then, obviously we have the amazing ability to access medication over the counter to treat thrush. But at the same time, if that's misdiagnosed or self-diagnosed and untreated, it's not going to work for that individual at all.
So with the vaginal, so we've got bacterial vaginosis and we've got candidiasis. What other major fungals are there out there, or is it just those two that we're really balancing with the majority of the population?
No, so what we know is that there is a fungal microbiome, or there's a microbiome within the vagina. And traditionally, because we've had culture-based methods, and most of the literature that we see discusses candida only, because that's very easy to culture. And so we have a different species other than Candida albicans, which there's still some issues getting that identified just on a culture level. And then we move into more specific fungal species that are non-candida fungal species. So there's a whole host of those. Some of them are implicated in vaginitis or in inflammatory vaginal conditions. Some of them are implicated in more systemic, immune compromised fungal illness, right through to, people that have mold exposures. We're seeing more and more mold type species coming up in those microbiomes as well. And so, Wow. In a long-term setting with recurrent thrush, there's this acceptance that the culture negatives are part of that presentation, that somebody can have recurrent thrush and have a culture and show no candida species. There are reasons why that can occur that are specific to candida also, in terms of the immune system response, and people who have allergies are more likely to experience recurrent thrush. So there's this hypersensitivity response that can occur. But there's also a potential that we're dealing with the fungal species that is not candida. And so a test that only looks for candida will miss if there are atypical fungal species there. And people that in our research, we looked at that fungal microbiome and saw a whole array of different species that came up for people. Some of them known pathogens, others just commensal sitting in the background. But it's definitely a new and emerging area. When I started my PhD, there was literally 5 papers written on the vaginal microbiome. And so that has expanded a little bit, but not much. And hopefully my paper will come out in the next 6 months and that will add to that as well. But it's a frustrating space, and I think one that we've sort of overlooked as being potentially capable of causing any issues for an individual.
Yeah. I mean, there is a lot of discussion of that in the news, isn't there, about how women's health is just like, and black women even they're so low on the scale, you're better off taking them to the vet than you are taking them to a hospital because of the care that they'll get. So in this space, you are one of very few people working in this space who've taken it to the next level, who haven't just stopped at, I'm going to work in clinic, I'm going to do this job for these people and hope for the best. I mean, I had no training in it all those years ago. So it was always, what can I do? What can I use? Let me do as much Googling and research and looking through papers as my actual clients who are rocking up. They already know what they've got and I can't swab it. So obviously this is the main reason why we're sending overseas, so that we can get all of these and find out all of the different species, so that you're actually attacking correctly. It's like I went to the doctor and I was like, what is this? Oh, I can't see it. It's on my back. I cut myself on roses and it felt infected. And she's like, oh, you'll need antibiotics. And I said, well, can't we culture, like, let's send off a swab? She's like, no, you just need antibiotics. And I was like, no, you can give me the prescription. That's fine, but I won't fill it until the swab results get back. And she swabbed it. And then she had to ring and say, oh, there's no infection. You don't need the antibiotics. And I was like, no, I just can't see it, because I can't, even with cameras and turning around and mirrors, I can't see what this rose has done to me, and my husband was away. So we've got all of these things where people are, they're fobbing us off. I was fobbing people off, really, because I had no research, I had no knowledge. I had to go with what others had done prior to me, which, now that I've done new education, I know was pretty wrong. Yeah, it's a bit of a worry. But the as we go forward in this space, we're sending, so let's get some basics down here. So I've got someone who comes in with with a smelly fanny, okay, and they've got some chunky monkey going on, and because we don't know what it is, so I'm going to say to them, I need you to stop everything for a week to 10 days if you can, and then we need to get this sent overseas. Then you can go back on whatever it is. Or are we doing other bloods? What else are we doing?
So it's very much case by case, because if it's an acute once-off presentation, I would go on clinical differential diagnosis. Let's get this person some relief, because that's important. And definitely I still, as a clinician, and everybody should be still utilizing standard culture and microscopy. It is the currently accepted form of differentiating these things. What cultures does matter in the sense that, if something comes back, then you've got quick information to act on that. But clinically, I think as clinicians, what we are seeing in the holistic space is the people that have had that for months and months and months. And so typically by the time they get to us, they already have a strategy for perhaps dealing with that acute presentation, or it's in recurrent thrush, for example, it's a milder presentation in the sense that you don't necessarily get all of that discharge that we see in thrush, but there is definitely inflammation, irritation, it's cyclical, and so people have, it's a horrible thing, they have a threshold where they're dealing with that, essentially. So for those people, I would say, well, I would really like to see more comprehensive testing associated with that. Can we order that? Because obviously there's a financial consideration and that's not viable for everybody. And if we can't, then we look at other options. In the meantime, if you haven't had a swab, let's get a swab. If you've had lots of swabs, I want to see them all. Like, I would like to see the historical swabs as well, because for swabs where we see gram stain, We can get an impression on what the health of the bacterial microbiome might be like. We can look at what fungal species are culturing, if they are there, what bacterial species may culture, which is minimal when we look at the aerobic things that will culture on an open plate, often will culture, but they're not the most common pathogens within the vaginal space. But that information is useful. And if we've got a microbiome in the works, and we know, I would ask somebody, where are you in your cycle? And we can work out, oh, that test will probably arrive here and you're going to have to wait. So in the meantime, let's do some things to give you some relief. Or I give quite specific guidelines around, as soon as you have swab, we start here. And we work like this until we get that data back, because I think that delay when people are experiencing symptoms is unacceptable. But there's lots of things to think through, obviously, and whether people are willing to come off support that they have that is holding them in a good space, then that's okay. Obviously, everybody has the ability to choose in that, and I just inform what's going on there, and then we look for certain markers. So there are some lactobacillus, for example, that are not native to the vagina. And so when I see them come back on a test, I know they're there specifically because somebody is using that supplement. So things like rhamnosus, for example. And rhamnosus shows up readily within the vagina when you supplement, which is why it's great as a bit of a bulldozer. But at the same time, it's not native. And so if it's there and that's the only lactobacillus, then that person necessarily may not have an optimal microbiome at all. And, down the track, my goal for people is always to move them to the minimal protocol, if nothing, to go back and let them loose in the wild, essentially, and live their lives happily. So to be able to do that, we have to understand what's going on with, where things are coming from on testing, and whether their microbiome has the goods to be able to hold and be stable in that as well.
So we've the question is, the client collects the swab themselves. Yes, they do for this. You're giving them the kit and they're swabbing themselves. Are there any other, do you do blood tests for them as well, like the hormone testing? So what else have we got in the testing realm that you're doing for all of these people?
Yeah, so with vaginal health, often we're looking at that estrogen-progesterone relationship. So that mid-luteal blood test is a good one to look at for estrogen and progesterone. I will look, like anything, there's still a systemic level of healthcare. I'm not just only focusing on the vagina, and that's where a lot of my teaching is that if you're only treating this as an external tube that, leads to the uterus, then you're going wrong. You have to think about the internal. Where is that person's nutritional status? Is their vitamin D optimal? Is their zinc optimal? What's going on with their iron studies? Are they flooding, bleeding? And is that a challenge in itself? And so those types of labs are the basics that I look at. We're looking at B12 and all of those sorts of things, just those general markers of health. And then depending on through case taking, what else comes up, are there autoimmune conditions we need to be considering or ruling out? Those are the sorts of testing that we would also look at and bring in, or, see what they've been assessed for previously and look at those markers as well.
Cool. So, you've said there's a protocol here. So that's part of your education, isn't it? You have a membership or an academy. How does it work with you? You've got because we can learn this stuff from you. We can come to you and do this education. I've done it myself long ago now, but I've done it myself. So how can people learn from you and learn this stuff and know what these protocols are and figure out when they're meant to send everything and what they're meant to do?
Yeah, so because a big part of what I realized is that I'm one person, and that the more I became known in this area, the more overwhelmed I was with the amount of people needing support in complex areas. So I educate practitioners, and so part of that is I have it's an intake of mentoring called Vagiversity. It runs for 6 months, and we meet twice a month with live sessions. So that runs twice a year. I also have an online school that has a number of short courses and webinars. And so in that is a foundations bundle as well, which has a lot of webinars and handouts and things like that, which is a great place to start if you're entirely new to the world of vaginal microbiome testing and treatment. And it also provides some, very basic understanding of, this is the result. Or if you're using some of the testing we have available, which is a little bit more limited, understanding the limitations of that test as well, so that you can make assumptions around that. So those are areas that I think you're going to put some links up, but you can access through my website, intimateecology.com.au, or I also have an Instagram where there's lots of information that we put out as well, and links are there. And then a Facebook online practitioner group as well, which is just for case discussion and research sharing, which is the Intimate Ecology group.
Yeah, that's great. It's and everybody who is now listening on the live, if you want your certificate for being live, you need to write Bradfield in the chat so that you can get the certificate. The certificates are only available for 7 days post each talk. So you'll need to write Bradfield in the chat to get that certificate sent to you by my VA. Via my VA. So, I mean, they've got to be valuable, haven't they, the certificates, because your work is so valuable. And we are so, as a group, I do feel that we can say that we are so proud to have you in our space and that you are doing this work for us so that we can come to you for that education and that training. So, I want to thank you for coming in this morning, and I know your time is very, very precious, and thank you so much for coming and speaking to us today.
Thank you for having me. It was great.
Great. Right, guys, we will catch up tomorrow morning again, and I look forward to seeing everybody then. See ya.